And with that, we'll kind of dive in. I wanted to start by giving just a little bit of background about what CareSync is and who we are, just so you kind of understand a little bit about who we are. We'll then dive into the code, the billing guidelines, cover the chronic care management and transitional care management elements, go through the benefits of CCM, what it takes to do CCM properly, some questions that I would encourage anybody to ask before picking a partner for your practice and taking on something as valuable and significant as chronic care management, and then again take that quick little snapshot of the platform and answer your questions. So at CareSync, we are a patient-centered solution that combines technology and services. For about the last 5 years, we've been developing the CareSync platform, first launched in 2011. About 3.5 years ago, we introduced care coordination services. And then about 1.5 years ago, we became Drummond certified. Core measures 7 and 17 are the most relevant measures of meaningful use, stage 2, that we're Drummond certified for in the context of today. And then as of January 1, our company has kind of shifted our focus a little bit from what used to be a B2C focus, going straight to consumers, rare disease, chronic patients, providing our services, now working largely with physicians to help them leverage the new opportunities CMS created with CPT 99490. A little bit about our team. Overall, we've got about 4 centuries of healthcare technology and services experience. Our team's built several EMRs, including the first cloud-based or .NET EMR. We, again, like I mentioned, launched CareSync in 2011 originally, and services back in 2012. And as we like to joke here, we've been doing chronic care management before it was cool, before it was a thing, before it was reimbursed. And so right now, as everybody's trying to figure out how to tackle this initiative, how to provide this benefit for the patients, how to help generate revenue for the practice in a pretty transformational reimbursement, it's really at the core of what we've been doing all along here at CareSync. So what is 99490? And I'm sure that we have folks on here that have varying levels of understanding of the code. Some people know it's the 20-minute thing, it's the non-face-to-face thing, it's the care plan thing. But what exactly is 99490? A little bit of history on chronic care management. CMS ran their own pilot in some of their rural health clinics last year, about 400 clinics, and they piloted the notion of 20 minutes at least of non-face-to-face qualified care coordination services. And then ending in the rulemaking process back in November, with a finalized rule November of 2014, CMS published an addition to the physician fee schedule as CPT 99490. It pays on average right at about $43. It's about a $43 reimbursement every month, and it is for Medicare patients that have 2 or more chronic conditions. And we'll dive into patient eligibility here in just a second. But one of the things that I try and stress to people in understanding chronic care management is that this CPT code, while it is as simple as a CPT code and something that you and your practice are typically billing on a daily basis, it's also a fairly transformational or revolutionary model of getting paid. It's really representative of the first time that CMS has said that you as a practice or that you as a billing provider can actually get paid for time spent when you're not hands-on or face-to-face with the patient. And so CMS kind of moving away from fee-for-service, and whether or not fee-for-service ever really goes anywhere, CMS has at least set the stage and said that we are going to start reimbursing providers for more frequent and less expensive encounters with the patient, rather than paying solely for the infrequent and expensive office visits. That's really the essence of 99490, but with any opportunity like this comes very stringent and difficult protocols that, if wrestled with properly, become manageable, but they are challenging. And so that's part of what we're going to dive in today, is to focus not only on the opportunity that's here, but how to compliantly and safely take advantage of this opportunity. I mentioned a second ago that all Medicare patients with 2 or more chronic conditions are the patients who are eligible to have this CPT code billed on them. One of the questions we get, or I get, is, well, geez, Jamie, what is a chronic condition? And Medicare has not, CMS has not published an exhaustive list of eligible conditions. To the contrary, what Medicare has said is that any patient that has two conditions that are expected to last at least 12 months or until the death of the patient and place the patient at significant risk of death, acute exacerbation, or functional decline has the eligibility requirement met. So you can imagine the number of quote-unquote chronic conditions that would qualify a patient here, something as simple as diabetes, COPD, congestive heart failure, but anything that in your assessment as the billing provider would meet the two criteria of either leading to the significant risk of death or functional decline and expected to last at least 12 months or until the death of the patient, documenting that the patient has those two chronics has met the patient eligibility requirement. Now, a couple of things in the enrollment process that need to be documented when you are talking to an eligible patient. One is to explain the chronic care management program, so to let them know the benefits, why the program makes sense for them, what the program involves, how the CCM services will be provided, whether that was CareSync, whether that was your own internal services with a software solution, that the patient has the right to revoke at any time, meaning that the patient at any given time can come to you and say, look, I want to opt out of this program. Explain to the patient that only one of their providers can bill CCM per calendar month. So once a patient has signed a consent form and enrolled with one of their providers, they cannot be billed on by a subsequent provider unless that prior consent was revoked or unless a new consent is signed. A universal HIPAA form, obviously that's important when you are talking about going out and getting records on behalf of the patient to develop the care plan that I'm sure you've heard some about and that we will cover here in just a few minutes. And then also notifying that the patient may be responsible for any copay. And certainly about 65% of Medicare patients nationally have either a secondary or supplemental care, insurance, and so a copay would not apply. And then another 25% of patients are going to be on some sort of Medicare Advantage plan, which may or may not have a copay there. But to explain to the patient that they may have a copay. Documenting that they have those two chronics, doing those 6 things and explaining to the patient what chronic care management is and getting them enrolled. And we've met the patient eligibility and enrollment requirements. Now, I like to try and explain to people that chronic care management is not simply, it's certainly not a unit code, but it's not just a time code either. There are technology requirements and there are service requirements or scope of service requirements. And so each month for any patient that is enrolled in the chronic care management initiative in your practice, there are the requirements that the full scope of services be provided, but there's also the requirements that they be provided in a qualified technology platform. And so CMS, without having kind of opened the doors to what that qualification looks like, has left it somewhat vague, but given us some specifics. So, for example, your practice must be using a certified EHR within your practice. There are some of the stage 1 meaningful use requirements that structured recording of demographics and meds, etc., be a component of chronic care management. But at the very essence of chronic care management when it comes to the technology requirements is the fact that we have to have a patient-centric care plan with information on all health conditions. That does not mean a patient-centric care plan with the information inside my EHR as my practice. I have to have a patient-centric care plan that can document and show input and feedback on all health issues. So if I'm a primary care provider and I'm doing chronic care management, I need to have input or documentation that the cardiologist care plan was incorporated or that the hospital discharge notes were incorporated, that I've brought all of my patients' information into one consolidated and patient-centric care plan. Now, once I have that care plan, I have to have the ability to update and share that care plan electronically with other practitioners and care team members 24/7, 365, or as appropriate. One of the things that CMS has made very clear in this chronic care management initiative is that they are trying to help push the ball forward on interoperability. And there's really not much of an argument that practices and providers have for far too long been denied the types of technology or the ability to easily share patient records between referring physicians. But when CMS talks about interoperability, and specifically with chronic care management, there's a couple of points that I like to make on this. Number one, expressly, faxing does not count. So if I have that electronic care plan, it includes information on all health issues, and my plan to get that to any provider who needs it is to fax it to them. I am not compliant with chronic care management. If I cannot share my care plan beyond my practice or my health system, I am not compliant. So one of the questions we get is, well, gosh, Jamie, I'm on, EHR named X, and another practice down the street is on EHR named X. Am I going to be compliant? Well, if you can get the care plan to that EHR named X as well as to the hospital with an EHR named Y, and be able to share that care plan with any practice, then sure, you're going to be compliant. But I also have to be able to get that care plan to a provider without a certified EHR. And one of the reasons I make that note is that sometimes people will say, well man, I have direct functionality or secure send functionality in my EHR, so I could just send the care plan via direct or secure to another practice. Putting my lawyer hat on and not ever wanting to have one of our clients see a compliance issue, I would suggest that if I cannot get the care plan to a provider that does not have an EHR and fax isn't allowed, I've got to have a way to get that there to be compliant with that. And so those are kind of the high-level technology requirements of this code, which moves us into the services side. And the biggest thing I like to stress when we talk about the scope of services every month for chronic care management is the fact that there's a time and scope component. So there has been a narrative that kind of suggests that you can spend 20 minutes on the phone with a patient or instant messaging with a patient, and once the timer hits 21 minutes to be safe, you tell Miss Betty Sue that you're done talking to her this month and you'll talk to her next month, and that fulfills the requirements of 99490. I would suggest to you that would be a very dangerous path to go down, because really what CMS has said is not just spend 20 minutes of non-face-to-face care coordination. It has said fulfill the full scope of services and spend at least 20 minutes doing it. So in essence, what that means is that if I was somehow able to automate the entire scope of services, I would not be able to bill, because even though I did the full scope of services, I didn't spend 20 minutes. Similarly, if I spent 6 hours but did not fulfill the scope of services, I would not be able to bill, even though I met the time component. I failed to meet the scope component. We've got to have 24/7, 365 patient access to the clinical staff. And one of the common questions that has popped up here is, well, geez, I have an answering service that takes calls for me after hours, and it may send me a page, a text, or a voicemail. Is that going to count? I would tell you that it is a cautioned. I would caution against having the patient speaking to somebody who is not a member of the clinical staff. And while CMS has again not defined specifically what the clinical staff is, from a safe compliance regulatory perspective, I would recommend that anything at a CMA or CNA level on up is going to meet the definition of a member of the clinical staff. I've also in order to bill compliantly on my patients, I have to give the patient the ability to create and set successive routine appointments. This is incorporated in some of the transitional care stuff that we'll talk about here in just a few minutes, but one of the things that we've got to do is give the patients this ability. We've got to have ongoing care management and monitoring for all of the patient's conditions, again stressing all, that it's not just the conditions I treat the patient for, it's not just the conditions that I have documented in my system, it's going out and proactively getting the information from all of the patient's providers to have that one simple patient-centric care plan that addresses all health issues and is regularly updated. A regular assessment of the patient's medical, functional, and psychosocial needs. We've got to cover medication reconciliation and adherence. So we've got to go through the med list with the patient, try and hone in on what the patient's taking, how often they're taking, what they're compliant with, and address medication needs. We've got to provide patient and caregiver access. And so that can actually be by mail. There's no requirement that the patient have electronic access. So interestingly enough, the CMS has said that the providers all have to have electronic access. The patient, on the other hand, can get electronic access, obviously, but also can get a paper copy. And then again, the regularly updated patient-centric health summary and care plan, coordination with home and community-based clinical service providers, and then follow-up after ER visits to help coordinate the transition of care, again referencing the transitional care management components of the code that are incorporated. Moving on to the billing guidelines, one of the questions that we get a lot of times is who can't bill and when can I not bill? Who cannot bill? CMS has not placed a specialty requirement, so to speak, on this code. So one of the things that we see is that certain specialties are starting to adopt the code pretty aggressively. I don't think there's any argument that CMS created this initiative as an opportunity for the primary care doctor or the physician that is, in essence, the quarterback for the patient's care, that is responsible for helping the patient navigate the healthcare delivery system. With that said, CMS has said any provider who will take on that responsibility for the patient can, in fact, enroll the patient and bill. There are a couple of exclusions: social workers, clinical psychologists, podiatrists are just a few. But for the most part, your primary care docs, your cardiologists, your endocrinologists, your gastros, just about any provider that is seeing the patient has the ability to bill with few exceptions. When you cannot bill, however, is best answered at a high level when the patient is in a setting where there is already a reimbursement contemplated by CMS or incorporated by CMS for similar care coordination services. So that would include inpatient in the hospital, a skilled nursing facility, a nursing home, or in hospice. We also can't bill within a 30-day period, and I'll show a slide just in a second to visualize this, but in the 30-day period that transitional care was billed, we cannot bill chronic care management. Obviously, you'd want to bill transitional care if the protocols of that were met and we made contact with the patient in 2 days. We scheduled the follow-up visit within either 7 or 14 days, and then we brought records back to the referring provider for review and meet those protocols. You would obviously want to bill transitional care, given that the reimbursement is approximately 3 times what chronic care management pays in a month. And once those 30 days are over, go back to billing chronic care management. And then when the patient is already enrolled with another provider. And so as we move further into the year and we're starting to see more and more practices around the country who are, I think, kind of now realizing that this chronic care management thing is for real and that it's not going away and that it does reimburse, a lot of providers are starting to say, well, gosh, I don't want to miss out on that, so let me go ahead and start enrolling my patients. Obviously, the further we get away from January 1, 2015, the more of a reality that some of your patients have already enrolled with another provider. But once they're enrolled with another provider, we cannot bill unless they were to revoke and sign a consent form with us. So I mentioned chronic care management and transitional care management a little bit. We talked about kind of high level of the protocols to bill transitional care. At the top of this slide, however, what you'll see, and this is to try and visualize some of the confusion, that chronic care management and transitional care management can actually be billed in the same month as each other. They cannot be billed in the same 30-day stretch. And so if we had a patient enrolled back in January, and then coming into February, we performed chronic care management services for our patient. From February 1 to February 15th, we fulfilled the full scope of services, did at least 20 minutes doing it. And then on February 15th, our patient went to the hospital, and we began the transitional care management work once the patient was coming out of the hospital. For the 30-day stretch from February 16th to March 15th, we could not bill chronic care management. However, if we fulfill chronic care management from March 16th to the end of March, we would then be able to bill chronic care management again in March. So it is not a calendar month. There is the preclusion that the services not overlap. And so we'd have to document that we did the full scope, met the time requirements from February 1 to February 15, as well as from March 16 to the end of March, and in that 30-day window in the middle, did the transitional care management requirements. So what's in it for the patient? And this is one of the things that I think is often overlooked about chronic care management. And what we've seen around the country and working with practices of all different shapes and sizes is that the critical importance to having patient enrollment velocity in a practice or a health system is for the patients to really understand that chronic care management is really about them. Yes, it's a reimbursement for the provider. Yes, it's going to help offload significant work from the staff if it's done right in your office. But at the core of it, it's really a patient value. And so articulating to the patient that, for example, in our scenario, the patient's going to own all of their health records forever. They're going to be able to access them from anywhere and any time. They're going to be able to share them with their caregivers, whether that's an adult child that lives across the country and wants to help care for his mom or dad. The patient owns all of that information that is inside the CareSync profile that is theirs forever. So if they revoked and they left, they would still have all of that information in there and have that consolidated patient record. Explaining how the CareSync process or the chronic care management process will actually help the physicians avoid prescribing medications that have interactions or help keep the patient healthier and out of the ED. Those are all components, and it depends on how you deploy chronic care management, but one of the things I would encourage your practice is to think about how the chronic care management solution you're looking at would benefit the patient, because when you're sitting down with the patient, and certainly patients with a copay, for that small number of patients that have a copay, explaining to them why there's a benefit is certainly significant when you're talking about having them potentially come out of pocket. But of course, the purpose of the call or this meeting this morning is really kind of summed up by what's in it for your practice when it comes to chronic care management. And we know that obviously the revenue component is talked about, but again, if chronic care management is done right, it should be something that significantly helps staffs and offices that are typically kind of scrambling, overworked, understaffed, trying to get through the day. Chronic care management has given you the opportunity, with CMS explicitly authorizing the outsourcing of chronic care management, to basically bring an extension of your office to the table so that your team may not have to continue setting appointments for patients enrolled in chronic care management, or they may not have to make records requests or send out, handle referrals and different things that your office is typically used to scrambling to doing. If chronic care management is right, we should be freeing them up significantly, giving them more time in the day to kind of get through and more efficiently process the patient population that day. But we're also going to help the physicians you're sending patients to. So in kind of the physician ecosystem, making it far easier for referring documentation to avoid duplicative tests, all of the things we want to see happen for us to ever accomplish the triple aim as an industry. Chronic care management gives us a big opportunity to step forward there. Obviously, avoiding interactions with on the medication reconciliation side is something that's significant when it comes to liability for a practice that may or may not know that their patient has 74 medications, 22 of which have a severe interaction. And before you laugh at hyperbole, that's a real-life example of a patient we've seen. And unfortunately, it's not as much of an outlier as we would like to think, but the reality is patients are seeing a number of doctors that we often don't know about. They're on a number of medications that none of their providers know about in some. And so bringing that all together certainly is something that helps protect and keep that practice safe. Meaningful use compliant, depending on how you do chronic care management. If you're using a system that is certified to meet the core measures dealing with patient engagement of meaningful use stage 2, what that should mean is that your office simply needs to enroll patients in the chronic care management program and know that stage 2 core measure 7 and 17 just became a heck of a lot easier to meet. And then lastly, HEDIS compliance and notifying you of opportunities to increase the HEDIS score, depending again on the platform and what technology and services are offering. The ability to help meet HEDIS measures more regularly is something that I would encourage you to think about when you're looking at how to do chronic care management. Now, one of the questions we get is, okay, how do I do chronic care management? I could hire up, I could use existing staff, I could fully outsource it. There's a number of ways to go about it. What we've seen in the market is that there are typically 2 different offerings or options for you. There are some people who can provide technology that would let you generate a care plan. Some of those even let you go out and aggregate records and develop a patient-centric care plan if you go get all the records from all the providers and put the information into that platform. And if you spend at least 20 minutes doing it, again, fulfill the scope of services, you'd be able to bill chronic care management. So what does it cost to do CCM properly? The other option is to have a turnkey offering. And there are a number of companies who are claiming to do turnkey offerings or have a turnkey offering where you would outsource the entire effort to them. They would do the entire initiative, and then you would be able to bill off of that and keep a portion of the reimbursement. What this slide is intended to be is a little bit of a resource for you when you think about, do I want to do it on my own or do I want to outsource it to somebody else? And I don't want to discourage anybody from saying, gosh, I shouldn't do it on my own and go get software that'll let me do it. But I do want practices to be aware of what is involved in it and what we have seen. So these averages are based on our team. We've got about 200 employees at CareSync. We have a health assistant team that ranges from CMA all the way up to RN. What we see is that the average hourly cost, once you span a spectrum of roles and experience, is roughly about $25 per hour average cost. I'm going to be able to process about 250 CCM patients every month with each employee that I hire for this initiative or each employee that I use. Now in months 1 through 4, and this goes to the opportunity cost and the time value of money, but in months 1 through 4, you're probably going to be closer to about 150, 160 patients. Towards the end of the year, you'll exceed 300, but over the year, it's about an average of 250 patients that an employee can process every month. So if you have 1,000 patients in your practice, I would recommend budgeting 4 new hires or 4 existing hires to perform those 1,000 enrolled CCM patients over the year. It's going to be a rough beginning. It'll get a little easier towards the end, but that's how I would recommend modeling out your cost. You'd obviously want to include in your cost of this the software cost. And so what would it cost to have software that would have you compliant with chronic care management? And then the other point that I highlight here, if you do it on your own, and I always kind of joke that as the resident recovering lawyer here in our office, I tend to get the regulatory questions along with our chief medical officer. But one of the two of us are getting the regulatory questions. We like to stress to people that we are happy to answer questions. We do not want to see anybody take advantage of an opportunity with an understanding of the code that's maybe inaccurate or a little bit flawed that ends up leading to compliance issues or liability. But here's just a couple of things to consider when you're looking at doing chronic care management on your own. I joke there at the end, we have seen this, we joke that your staff may hate you. And the reason that we have that in there is somewhat tongue-in-cheek. I would tell you that there are 2 very distinct types of practices when it comes to chronic care management. One has the infrastructure, the support, the space, and what it takes to do chronic care management on its own. The other does not. And sometimes they think they do. And what we've seen in those practices who try when they don't have that infrastructure and support is that they're really not onboarding patients, they're really not billing patients in anywhere near the opportunity that they have from a patient volume. And part of the reason they can't is that the staff is sitting there looking at the doctor saying, look, doc, I understand you want the patient enrolled, you want the scope of services, you want at least 20 minutes, but what am I supposed to stop doing off of my list of assignments or responsibilities in this office? And so we put that in there as a somewhat of a joke, but also somewhat of a heads up that the code is more complex sometimes than some people think. So what it means for you from a revenue potential, and we've thrown this in here as kind of gross revenue. Obviously, as you consider chronic care management options, the net revenue would obviously be these numbers in green, less the cost to compliantly bill. So whether you did it on your own, whether you outsourced it, bake in those costs. Those costs are going to come out of these numbers in green to let you know what your opportunity is on a per practice basis. As a note, if you were to take your number of patients or your number of patients, your percentage of Medicare patients, right at about 70% of Medicare patients on the national average are going to have 2 or more documented chronics. What we've also seen is that when you, for example, instituting a well-run and efficient annual wellness visit program in the practice, oftentimes starts to document or diagnose patients who may have 1 documented chronic with CMS that just have not been diagnosed with that second. So that 70% number is probably the floor of what to expect in your practice. The actual number of Medicare patients, or the actual percentage, is probably a little bit higher than 70%. But you'll see here that we put 3 scenarios: 500 patients, 2,500 patients, 7,500 patients. Really, this math is pretty simple and straightforward, but it's that number of patients times 43 for the approximate national average, and then times 12 to get the annual opportunity per year. Now, one of the things that I would encourage you to file away and keep as a resource, and ask anybody who is telling you that, hey, we can do chronic care management. So this would be for internal staff. If we've got folks on staff that have joined our call and the doctor is telling you to go do chronic care management, these are the questions to ask the doctor and say, hey, how are we going to do these? If a vendor is talking to you saying, hey, we can take your chronic care management work and generate revenue for you, take the hassle away, here's the questions that I would recommend going through with them. So starting at the top, one that I think is critical in to be able to show that we have all health, patient-centric care plan with information on all health issues is, hey, look, do you go collect records from all of the patient's providers? Are you going to go get me the records from the cardiologist office or the endocrinologist office, or go get the hospital discharge notes? How can a doctor outside my practice or health system that has a certified EHR electronically access the care plan? So in that scenario, 2 doctors that both have a direct address and use direct may be able to share it that way. If they are on the exact same version of an EMR, they may be able to send a CCDA another way. But then we come back to the second question, how can a doctor without a certified EHR electronically access the care plan? And as a note here, we do often note that carrier pigeon and Morse code are not options. So that is your bad joke for 8 o'clock in the morning. But in kidding aside, I have to be able to get an electronic care plan to a doc that does not have a certified EHR. The 2 most efficient ways that I know of to do that are either internet access for that provider to log on somewhere and be able to see something, or mobile access. One of the other things that comes up from time to time is as I work with health systems and larger enterprises around the country, it is remarkable sometimes how they say, well, gosh, what does it cost me on a per patient basis? And I always say, look, we can talk about what it costs on a per patient basis. The real question is, what does it net to your bottom line? So we could talk about the number that doesn't have a line under it under the balance sheet, or we could talk about the number that has 2 lines under it under the balance sheet. And in business school, I was taught to care about the number with the 2 lines under it. The reason I mention that is that there's these next 2 questions. When you're looking and assessing your revenue opportunity in the practice, these 2 questions are probably more impactful to your revenue opportunity than anything else that could be asked. Number 1, can I enroll Medicare patients that do not have a computer or a smartphone? If the answer to that question is no, then go back to the revenue slide and deduct 40% off of the number of patients. On the national average, 40% of Medicare patients do not own a computer, have smartphone access. And so if your chronic care management solution is dependent on the patient downloading an app or having a computer and logging on or understanding what the interwebs or email are, you are not going to have 100% adoption. You are going to, at best, have 60% adoption. So that's my enrollment potential. The second question I always tell people to ask is, what is my fulfillment potential? And what I mean by that is, can patients be billed compliantly in the model even if they don't spend 20 minutes communicating with a member of the care team? So whether that's an instant message feature, whether that's a call, a 20-minute call, or an aggregate of 20 minutes in either setting, am I dependent on capturing and lassoing patients in order to bill? And what I will tell you is that if we took that first number and we ended up with our number of maximum enrolled potential patients, we could probably deduct about half of those patients that are going to be passive patients in this program, who believe that their doctors should have all of their information, that believe that they should have the tools, their caregiver should have it, but by golly, they do not want to log on to any system. They don't want to be an active participant in tracking med adherence. All they want to do is know that it's there. Those are going to be the passive patients. The other 50% on average are going to be active patients. But if I'm dependent on lassoing patients and corralling patients for 20 minutes, my fulfillment potential is going to be down about 50% of the enrollment number. So those two questions are critical to understanding your revenue opportunity. Now, a couple other questions to close with on this front. Will your solution, or will we be scheduling appointments for any provider for my patient? So when my patient needs to go see a dermatologist, are you going to schedule that appointment for me? If they're leaving the hospital and need to schedule an appointment, will you schedule that appointment? In a provider or health system agnostic way, go out and schedule that appointment for my patient. Critical here for managing the transitional care components of CCM. Just a couple of other things. Do you do on-site implementation of customized workflows? That is something that I would stress you should expect of anybody who's coming into your office and offering to be an extension of your practice. This really is the first time, that CMS has said, look, you can kind of subcontract out an extension of your office. Well, I will just tell you from the non-clinical, non-physician side of this equation, it seems to make sense to me that the non-physician, non-clinician coming into your practice ought to fit into your workflow and meet your needs rather than forcing you to meet mine. Will your CCM solution help me with meaningful use? Not a requirement for chronic care management, but it does speak to the opportunity that chronic care management gives in order to make meaningful use go a lot easier. And then lastly, does your platform speak the native language of healthcare? The reason that this is here, and I wouldn't argue with anybody that this is a bigger picture, longer tail item, but what CMS has said is in essence that you can use chronic care management to lay the foundation for the next decade of health reimbursements. As fee-for-service starts to go away, if CMS ever really does eliminate fee-for-service, chronic care management done right, going out and getting all of the records on a patient from all of their providers, creating structured or discrete data that is useful in any healthcare legacy system, means that at a day when you need to have insights into your practice and see how many of your patients have COPD plus diabetes, or how many of your patients have congestive heart failure and are on drug X, having the structured discrete data there makes those insights and analytics possible when you look at the potential of value or outcomes-based models that are coming in the future. So very, very, very briefly, because I'm sure some of you who have not seen the CareSync platform before would like to just see very, very briefly what we do. What I'm showing you here in about 2 to 3 minutes is a sample account for a practice. You'll notice that the practice gets their own branding, their own naming, their own software. They have the ability to search any of their patients so that managing 10 or 10,000 patients is possible inside of CareSync Pro. We have all of our secure messages that have come in from a patient or a caregiver on behalf of a patient. And then we have these tools here to be able to add members at the same time, add related caregivers, to manage members, to see a meaningful use report, to see how many of our patients have met view, download, transmit, or secure messaging. We can actually attest from right here and be able to see on a per provider basis any date range with the denominator number of patients, run a report and attest. And if we're doing a good job enrolling our patients to help meet meaningful use or just to get them enrolled into chronic care management, we're also going to have this CCM report that's going to show us the last name, first name, date of birth of each patient. Again, can be broken down by provider as well as date range. We can run a report so that we know exactly who to bill on at the end of the month. But very, very briefly, just to show you a sample of what we do for our patients every month and what a patient-centric care plan with all health, with information on all health issues looks like. We start with our health history or the health summary. That is effectively our version of a face sheet. Who the patient is, what they have, who's diagnosed, who's prescribed, what they've prescribed, All of those important questions. Medication adherence data, if the patient or the caregiver is tracking it. If they're not, then it'll just say no medication adherence data available. Any PRNs or procedures and labs. Measurements over the last 30 days. So if a patient has connected one of about 100 wearable or remote devices that we integrate with, and they've connected that with their CareSync profile, every time, for example, Florence takes her blood pressure with a with a TellCare glucometer, that data point is going to show up here, or it can be manually entered. But we're going to be able to trend and see different measurements on that patient. All providers by specialty type, insurance and emergency contacts. And then we move into the care plan. And so again, breaking down the care plan by disease state, including any important notes, goals, tasks, or related items. And we're going to do that for each disease state. Florence is obviously a very, very sick patient, but she's dealing with a whole lot of doctors, a whole lot of appointments, and a whole lot of conditions. By breaking this down by disease state, we can see what each of those individual care plans in a specific office looks like in context with the greater consolidated care plan. And then lastly, a snapshot of the patient's timeline. So as part of what we do, we recreate every episode of care the patient has had. That includes transcribing visit notes. That includes populating the structured data points as far as meds, allergies, conditions, procedures, providers, correlating those things together to, again, make that data useful. And so what we're seeing here for Florence is the last 6 months. Snapshot of her timeline. One of the questions we get is, well, gosh, Jamie, you talked a lot about how we can't necessarily just send by direct, or we have to get the doc that doesn't have an EHR, we have to get him electronic or get her electronic access to this care plan. You'll notice here that we have the ability to print, which obviously doesn't meet the CCM requirements. Fax, the healthcare industry's favorite device. You'll notice that we can pick a provider and fax. Again, sharing this via fax does not meet the chronic care management requirements, but you do have that tool. And then we have the ability to direct send. So if we know that provider's direct address, we could come in here, enter that direct address. We can also download the data via blue button, whether a CCD file or a PDF. But most importantly, if we look at this list of providers right here, every single one of those got phone calls and faxes giving them instructions at how to create their own, an invitation to create their own CareSync account, where all they need is internet access to view the care plans that have been shared with them. And so when people ask, why would we want to, what's the importance to me? Why does it matter to my office? Here's just one hospital visit that I like to show from an ambulatory setting. Florence went into the hospital in August. Florence went into the hospital on April 6th, to Florida Hospital Central Care, and we've transcribed the visit notes. You've noticed here that the provider notes, the SOAP notes have been transcribed. We didn't have any related procedures. We did have 2 related conditions. We had related medications. But what we've done in going and getting all of Florence's records from all of her providers is actually pulled out the source documents, so that in this case we can actually see the x-ray image. We can also see the x-ray report and see if we agree with that analysis. And then the third document there, similarly, is just the ER visit, the discharge instructions. And so when we go back and we recreate every episode of care, that's what we're doing, correlating all of the structured and relevant data together, adding the provider notes, giving you the ability to filter it up here by date range, provider, appointment type, health condition, or medication, so that, for example, if I wanted to see my patient just with respect to COPD, I now have a timeline of all episodes that dealt specifically with COPD. And then lastly, for the quick overview before we get to questions, the ability to send messages. The one thing I like to highlight here is group messages. And so I have the ability from my Kerr Sync Pro account to send actually a group secure message to the entire care team. So Florence, her primary care provider, the CareSync health assistants, and then 2 non-professional caregivers can receive a message that says, look, Florence needs to have a bone density scan, Florence needs to have a follow-up appointment, please let us know if she needs a refill of her prescription. Any of those things can be messaged here to any individual or any subset or all of the group. And so with that, we will go ahead and take questions that have come in the course of this. I've left my contact information up. I can't thank y'all enough for spending some time with us this morning, but my contact is there in case we do not get to any of the to some of the questions that have come in. So we are going to start with, can a chiropractor bill? CMS has been a little bit vague on this. Right now, the answer is no from a safe perspective. I would not recommend having a chiropractor bill this code. If you are on the call, we will contact you and provide some supplemental information to you on how the initiative works with respect to chiropractors. But I would say the safe answer is to start with no. Can a pharmacist bill? Same thing. What we are seeing is that several of the large pharmacy companies are trying to come into the chronic care management space and do chronic care management in conjunction with whether it's a doc in the box, whether it's a billing provider that's on site in a large pharmacy, and offer a chronic care management solution there. But the pharmacist, himself or herself, cannot bill. The next question that came in from somebody is, does the CareSync platform integrate with the EHR, or is it a standalone system? The very quick, simple answer is that yes, we do integrate with a couple of large EMRs. The first two that we have partnered with are Allscripts and Athena. For us, we've taken a little bit of a selective and deliberate process of integrating with the EHRs, in the sense that we want to integrate with EHRs that want partners, that want to open up and make the data accessible to you and to the patients and to the caregivers. And there are certainly some EMRs who believe in that and some who do not. And so Athena and Allscripts is where we started. That list will continue to grow. What I will tell you is that our workflow, and we'll follow up with you that asked the question to explain kind of in greater detail. What I would tell you is that there is no requirement that any CCM solution actually integrate with your EMR. What's important is that the consent form and the indication that in the initiating visit we explained chronic care management to the patient show up in the EMR. The care plan has to be housed in technology that allows any provider to electronically access it 24/7. Which is part of the reason that CMS has not dictated that the care plan be in the EMR or the EHR, given the fact that most EMRs and most EHRs are not going to allow you to send some sort of link or permissive sharing of a care plan on an individual basis. The next question that came in for us is, what is the cost of our practice solution? If you will contact us, we will be happy. We often, depending on implementation, workflows, put together a quote for our practices, knowing that the size and scope of what we do varies. But if you will shoot me an email or give me a phone call, we can walk you through kind of the options there. What I will tell you is that none of our options come anywhere close to taking all of the reimbursements. In each of our scenarios, the practice, depending on how much or how little, whether you have somebody embedded in your clinic, whether we are on site for 1 day or 1 week or 1 month, all of those options available to you, but in none of those scenarios is chronic care management ever costing you anything out of pocket. The type of training for your staff is another great question that came in. The type of training is going to vary. So we have some practices who have actually opted to do a remote implementation, and I will go ahead and give you the caveat that I hate the I word because it makes it sound like something's going to be difficult or a pain. We do have the ability to remotely get practices going. In our turnkey offering, the training is significantly less, obviously, than in the software-only model where your staff would be doing all of the chronic care management work. But that's just going to depend on your practice. What I will tell you is that in each of those scenarios, we can have a practice up and running within a day. Somebody's on top of it. The patients within a federally qualified health center, I'm going to add a rural health clinic because those two are in the same bed here. The reason that I say that is that in fiscal year 2015, CMS explicitly precluded the FQHC and the RHC from chronic care management. The good news is that the current proposal for 2016 is to allow the RHCs and the FQHCs to bill. And so if you are an FQHC or an RHC, please do not hesitate to reach out to us. We have a couple different ways to help you gear up for 2016 if that is something you're interested in, so that beginning January 1, Lord willing, CMS gives you the ability to bill, and we have you set up to do that in a way that doesn't cost you anything. Does CareSync provide its services nationwide? Wondering, since this webinar started at 4:30 PST, where you are at. Now, I should share with you that there was actually a 7:30 p.m. offering, which would have been 4:30 p.m. for you. But yes, I will tell you that I have the distinct pleasure in this office of being one of a handful of people that are blessed to work East Coast mornings and West Coast nights. So specifically for you, I will promise you a 10:30 p.m. and 10:30 a.m. Pacific Standard Time version of this series for you. But yes, we actually have a number of practices out west. A number of states, excuse me, with practices out west, so running all down from Washington State all the way down to the southern tip of California. So working with the VA, somebody's asked the question, veterans that are allowed to receive care from a non-VA PCP due to mileage. That's actually a fantastic question. I have been working a little bit with some contacts at TRICARE. TRICARE has not been very friendly to chronic care management to date. We are trying to change that. Certainly it seems that a man or woman who gave their all to serve our country ought to get the same exact benefit that a Medicare patient gets. Currently, TRICARE does not share that sentiment with us. We are working to change that. But the question specifically with respect to a VA patient who gets to see you with non-mileage is a fantastic question. Our chief medical officer, I should have mentioned, is a physician champion with CMS, pretty direct line of communication to CMS. I will get an answer to that question. That has not come up, but that is you win question of the day, so you can collect your prize after this. But we will get you an answer to that here in short order. A couple of other questions that have come in. Can I enroll a patient without a face-to-face visit? The answer to that is no. CMS initially kind of created that opportunity, gave that setting a chance. I don't think intentionally realized that that was going to maybe lead to people taking advantage of this, telemarketing direct to Medicare patients. So they quickly put out clarification that an initiating visit has to happen. Those three initiating visits can be an AWV, they can be an IPPE, or a qualifying E&M. One of the questions that's come in, shouldn't a compliant AWV create a care plan for you? The answer to that is yes. And this is a whole nother webinar series that could be done. But CMS has really created the second half to the coin that they started with AWVs. AWV should really be the detailed investigatory process of sitting down with the patient, spending 20 to 30 minutes with them, going through all of their conditions, doing the deep dive assessment that, if done right, should generate a patient-centric care plan. Chronic care management should be the extension and carrying out of that care plan. So that AWV being done with patient answers and giving you information from the patient perspective, chronic care management then going out and getting all of the records from the various other providers, bringing both of those things together so that every year you're starting your patients with an AWV, you're immediately rolling them into a chronic care management program, and then in month 11 scheduling that next AWV to roll back into the AWV. Coincidentally enough, one of the most interesting statistics in the Medicare population is that 50% of Medicare patients change their primary care doctor every 2 years, 30% change them every year. And so when you think about getting your Medicare patients into a consolidated workflow from the AWV through CCM, it provides you a tremendous opportunity to retain those patients. Last question that came in, because I know we're up against the 8:28. Well, we got a couple. I'll try and squeeze in. How long does it take to launch a practice? That is pretty quick. Candidly, that depends on your practice. So in our workflow, we demand that you give us access secure and authenticated to your EHR. The reason we do that is for your benefit and our benefit. Our benefit, so that we can get to work right away and get working on your patients. Your benefit, we're not going to get you set up with this great new thing called chronic care management and then immediately send you hundreds or potentially thousands of records requests for the patients you've enrolled. You'll never have to deal with those records requests with us. The last two questions, and I apologize for being quick, but we try and honor the hour window we gave you so you can get onto your day. Who bills? The billing provider bills. I can't speak for other options, but at least with us at CareSync, we're going to send you an invoice and a billing report at the end of every month. The billing report is for you to use right away. The invoice is for you to use 30 days later. So we actually front the services. We go ahead and give you the ability to get reimbursed by CMS first. You're going to get our invoice and billing report, one use right away to get paid, pay us 30 days later. And so that's how the bill is done. Lastly, how does the patient have electronic access to the care plan? In trying to be very short, and I should have made the ask, if any of you would like a more in-depth demo that would kind of cover the mobile applications, the web application for the consumer, I certainly wanted this to be educational first and foremost to give you a little context about CareSync. But if any of you would like to see a telepresence demo or have a phone call, my email's right there on the screen for you. It's james.grant@caresync.com. For those of you who are already working with, I know we've got some folks that were invited by members of the CareSync team. Those members of the CareSync team that you're working with can certainly do that demo for you as well. And so if you have any questions, that is there. Soft copy billing report. Yes, sir, you get soft and hard copies of the billing report. But to finalize the question of how does the patient have access to the care plan, there is actually the patient-facing side of what we showed you today. So you got to see the enterprise or physician interface. The patient actually has their own interface where they can add caregivers, add family members, and be able to take care of their entire healthcare world in one simple place, either to have people care for them or to help care for others or do both. So with that, I would like to extend a big thank you for spending your morning with me, especially to the gentleman who got up at 4:30. I thought getting up at 5:45 this morning was rough, but he wins. So, hey, thanks, guys. I really appreciate it. We look forward to hearing from you and hope you have a great day.